Hello and welcome to this national webinar series on Discharge to Assess. My name is Callum McGregor and I'm an Improvement Manager with the Emergency Care Improvement Support Team. We are pleased to present, along with national partners, our Local Government Association and the Better Care Fund team, the fifth in a series of 7 webinars on Discharge to Assess. Today's webinar will focus on workforce, and I'm pleased to say we have 2 presentations today that will cover both social care ethical framework from Sarah Mitchell. Morning, Sarah.
Good morning, colleagues. It's Sarah Mitchell. I'm Care and Health Improvement Advisor from the Local Government Association.
Thank you. And we also have some local experience from our Swindon colleagues. We have Claire Deeds.
Good morning, everybody. I'm Claire Deeds and I'm the Head of Social Work for the Adult Services in Swindon Borough Council.
Thanks. Hi, Claire. And also we have Jo Williamson from Swindon. Are you there, Jo? Okay, hopefully we'll get some connectivity soon. Just to let you know, after the presentations, there will be an opportunity to go through the question and answer session with the team. So my colleagues Angela Bullivant and Helen Bennett will be there in the chat room, kind of processing and theming your questions. I will also be posting a couple of questions to you in the chat room during the presentations. So if you can share any experiences you have with us, that would be fantastic. And we aim to close around 12 o'clock. So without any, if we go through to some housekeeping. So as this is again as an MS Teams live event, you will not be able to speak during the event, so every participant will be muted. We have the chat room available, so please post your questions there to the speakers or the panelists. This will be recorded and we will send out a link to the recording and provide you, all the participants, with the slides after the event. If just to check that when it comes from the Better Care Fund team, sometimes it's been going into people's junk mail, so please just check your junk mail because it might be sitting there. We only have one more webinar after this relating to our webinar series, but hopefully you found them interesting and informative. So I will hand you over now to Sarah Mitchell with our first presentation.
Thank you, Callum, and good morning, colleagues. And as Callum said, we really appreciate the time that people have taken to come to these webinars and really appreciate your feedback on how helpful you found them. We've tried to look at all the issues that are coming up with the new discharge guidance. And one of the things that we've noticed in relation to workforce is the need to for people to have a reference point really for how to make some of the very difficult decisions that we know that you're making on a daily basis, but also to help you to think through with the new guidance, how does this fit with my ethical framework as a social worker, but also as a social care worker. And health colleagues have talked to me about the fact that they have found this really helpful as well, particularly working with people at the point of discharge and on ongoing work in the community. So if we just go on to the next slide, you can find the detailed framework obviously on the website. And I think one of the things that people have said that they found really helpful is in the real pressure that's around and sadly that we're going back into, the importance of just thinking through how to have those really difficult conversations with people, how to make sure that we are putting the person at the centre of all of the discussions that we have, to help with the kind of planning and decision making that reinforce our values and our principles, and so that we can do all that we need to do in terms of getting people out of hospital to the right place and to get the right care, but actually we do that in a way that we feel comfortable with and we feel that we've been able to do to the best of our ability. That bit about being respectful, it's really important, and forgive me because you might think, you know, we know this is what we do every day, but sometimes we've had feedback from people that it's really hard to do that in the current pace and of change change and the pressure from the pandemic. So making sure that people still have their rights, their personal choices, and that safety and dignity matter. And some of those things around discharging at the right time of the day, making sure that families are all aware of what's happening, making sure that the person themselves has been involved and understands what's happening for them, and are able to influence the decisions that are made around them. And that comes on to the be reasonable bit. The thing that we're so steep sometimes in the process and the pressure that it is really important to make sure that people have got the reasons for what's happening to them. There's a real justification, and it's about the person. It's not about the beds. It's not about the pressure that any organisations are under. It's actually about the person, that we're making the right decision with them and for them, and always making sure that we are giving due attention to safeguarding issues. And we know that actually a lot of people have really suffered from some quite extreme psychological responses to having experienced COVID. And, you know, that population might be the under 65 population as much as the older population, and that actually understanding that and supporting them to be able to go back into the community with the kind of recovery support, but also wider maybe voluntary sector and other community support to help them to re-establish themselves in the community. And then the other bit is the importance of including others and making sure that they're included in decision making. And as a hospital social worker for a lot of my practice years, that can be really hard to do when the pressure is on and when people want to expedite the fastest and often the most appropriate solution for people. But actually the person themselves may have particular concerns, they might have particular things they want to share, and making sure that we do that in a way that recognises the very different circumstances that people might experience coming from very different communities. If we could go on to the next slide, please. That's going to be the saying of this pandemic, isn't it? Next slide, and are you on mute? Is going to be what we all remember. So the next bit is making sure that there are no mistakes, accountability. That's really hard. We all make mistakes, even in the best circumstances and with the best will. But it's actually about helping each other to recognise those, to learn from those, and being transparent about why things are happening and responsible for communicating them, and all of us sharing in the fact that if we collude with the blame culture and we don't challenge that, then actually that's when more mistakes get made, because people are scared of admitting to things that might be going wrong, or things that they haven't done, or they didn't feel able to do, or they couldn't get the resources for. So that leadership piece, and it is a really big leadership piece, about being transparent about why decisions are made and how we communicate them and hold people to account, is important across the whole system. That's not a social care issue, but it's actually making sure that we support and empower staff to be able to make the right decisions for people, and we manage that risk and we acknowledge that risk. What we know is a lot of people do stay sometimes in the inappropriate setting of an acute bed because we're feeling a little bit risk averse in terms of making bold decisions for people and with people, and it's about supporting people to do that themselves. The other bit is about flexibility, and we do love a process in health and social care. We do love a standard operating procedure. We do love the things that in a way can sometimes feel quite safe, but it's actually about being responsive and being able to respond to both the patient in terms of what they want to happen, but also that wider workforce and that wider sector. That collaborative working, creating a culture of collaboration is again a really important leadership piece, but we can all do it in our own behaviour. and the way that we speak with people, you know, the way we send those emails. And actually, at times of pressure, that's even more important. It's also more difficult to do when you're feeling that pressure, you're exhausted, you've been here before. It feels like every winter is like this. Why can't we resolve it? It's really hard to do, but it is just sometimes that little moment of pause and reflect to think, actually, am I being too rigid here? Can I do this differently? Can I have a different conversation with this person? Can I have an offline chat that helps us to understand this a little bit more? And making time for that in what is a really pressured environment. And it's also about being fair, that kind of proportionality. And that's the bit about making sure that also we're distributing resources across that wider population. So making sure that support is proportional to needs, and actually that we're not into over prescribing care. We get a lot of difficulties sometimes, and actually delays, because we've said, oh, it must be for example, 4 visits a day, and it must be 2 people. This person won't be safe without that. It's actually about being really needs led and looking at what people can do for themselves, what people might want to do with families and other services, and tailoring that support to be centred around their individual needs and abilities, and actually then getting more likely to be a much more successful discharge and a much more successful stay in the community as people do that. And then the bit about working together in the community and supporting one another. We've seen some fantastic examples of collaboration. I think people absolutely are working so hard at the moment, but also working so differently to support each other and understand each other's pressures. And in a way, we really don't want to lose that as we go into this winter. And with all the pressures coming and the expectations of government, of guidance, of senior managers, it's sometimes really hard to continue to do that. But it is absolutely what we need to do in the way that we work together in order to get us all through it, actually, and to do the best by the people that we serve. And again, just if there's any opportunity with your colleagues, whoever they might be, just to take some time to think about, so how do we want to work together through what is going to be probably one of the most difficult winters we've ever had, and in implementing new guidance, just please take that opportunity to do that and have a think about this wider framework, this ethical framework for social care being a wider framework for your health and care system. Thanks, Callum.
Thank you, Sarah, that's great. So we'll move over to Claire Deards from Swindon Borough Council.
Thank you, Callum, and thank you, Sarah. You'll be reassured to know that there's a lot of recurring themes, as we would expect in our presentation as well. So Joe and I have been asked to come today and talk about the implementation of the discharge to assess principles and the policy, specifically through the lens of the workforce and how we manage that locally here in Swindon. So introduction's already done. So I'm Claire. Joe will follow on from the latter half of the presentation. We're going to talk to you about five key areas, really, about how we implemented discharge to assess in the Swindon system. We'll talk to you a bit about some of the frameworks which Sarah has already outlined, about some of the individual enablers, some of the system enablers, and some of the community enablers, and also with some of the challenges that we faced and still face now. So I think, for me, the most important thing that we were able to support the system with was very visible leadership and very leaders who were very comfortable with being uncomfortable about the changes that were happening, and how we used the framework around these changes as leaders to set the scene and to be really clear about the vision. So anybody who knows anything about change management knows the first thing you must do is establish a really clear vision. And I think some of the policy and the guidance that we received from central government at that time really helped us to do that. So we use those frameworks to set the scene, set the vision, but also to explain that motivation for change so that people very much felt like they were with us on an agreed journey. It was really important for us quite early on in Swindon to make sure that the policies and the guidance and the what felt like almost a constant flow of changing information from many areas was understood at what it meant for that system at system level for Swindon. So was my interpretation of the policy the same as the CCG's or the NHS's? So it was important for us to have some very high level strategic conversations to make sure that we were all interpreting the policy and guidance the same. And once we'd done that, then I think the other thing that we did that was a real enabler was just sharing all of that out with everybody and understanding that some people might want to read through it with you. Some people were quite happy receive it as an email. Some others may prefer a Microsoft Teams call to talk it over. But sharing it and communicating what was the relevant guidance. The key things obviously being the hospital discharge guidance as it was in March, and then more latterly as it turned into policy in August. I think what was really good and what was really helpful were the NHS action cards, because what they showed you was very different, what was expected to be seen as different by each role. And that was really helpful on two fronts, because you could look at yourself through those action cards and find your particular role, your profession, and understand the changes it meant for you and how you are going to have to think and behave and do things differently as a result of the response. But also it gave a really good insight to everybody else about what your role was and what could be expected from you. So it enabled us across the system to offer a bit of challenge to somebody who perhaps wasn't changing at the pace that was required in those early days. So I think the NHS action cards were a really good success and something locally we want to think about when we take further changes forward. And I think some of the big frameworks, so the Care Act, 2014 Care Act, which is the biggest mandate really for social care and the way we operate, but it was about making sure that people saw those frameworks as enablers, not barriers. So very early days, some very late nights, we were very interested in looking particularly at section 2 around the preventing and reducing and delaying of need. And actually, when you really read that, the spirit of that is all about supporting people in the right place at the right time. And it's never the right place or the right time for people inside an acute hospital during a pandemic. So using some of those frameworks to actually make the enablers for some of the change. MCA came up a lot. We talked about mental capacity assessments more than we talked about anything else, I think, during the early days. And because our social care teams moved out of the acute sector, our health colleagues were left kind of holding the baby with MCA in a way that perhaps they hadn't done before. So health colleagues reacted very quickly to that in terms of training, but also we had to look through MCA through a slightly different lens in terms of making sure what we were doing was in that person's best interest and was the least restrictive thing we can do. And again, when you turn MCA on its head, it's easy to argue that it is the best thing for somebody to be able to leave the hospital as quickly as they're able to. And it's always less restrictive to make any decisions about somebody's long-term care outside of that acute environment and preferably in their own home. So it was important for us locally to use these frameworks as enablers. And then there were some individual enablers, so things people did. And when I reflect on the success we had in Swindon, it was the people, those individual people and the way they thought, behaved and reacted that made the biggest difference. So one of the big successes for us now is to have a dedicated lead for our head of integrated systems of flow, known locally as FlowJo. And FlowJo didn't know that she was going to appear in this form in this presentation until she received the slides at the same time as everybody else this morning. But that's very much how we see FlowJo, and isn't everything easier when you've got a bit of a superhero on your side? And what FlowJo offers us as a system is some objectivity. So she's joint funded. Jo's post is joint funded between SBC and the CCG. So she is able to come in on top of ourselves as a local authority and our trust and help and support and challenge us to get it right for the person in the bed, but to do that from an objective place, which has been really successful. Relationships, not only with FlowJo, but with all of our other colleagues and our networks of support, those are the things that made the biggest difference in those early days, to be able to reach out to people that you have an established relationship with, or reach out to somebody who you don't and ask them for help, explain to them what you're struggling with, and build that network of support around you, so that when you're on your own and making a quick decision, you've got people that you can reach out to. That was hugely helpful in the early days of the changes. Communication was key, so keep saying the same things over and over again, keep reassuring, keep revisiting that vision, and keep being visible when you're doing those communications. We talked an awful lot through MS Teams, through phone calls, through Skype calls, through WhatsApp groups, you know, at all times of day and night, to make sure that we kept that communication up about what it is we were all trying to achieve together. And I think encouraging colleagues to talk to each other more. So when somebody didn't know something about how it was going to work within the acute or from the CCG, actually just saying to that person, do you know what, go and make contact, go and talk, encouraging other people to build their network of support around them, and explaining the benefits that individuals can make. So explaining to somebody, if you do this, this is the difference, this is what will happen if you make this change, if you change this behaviour. People are, you know, far more likely to come along with you after those sorts of conversations. We had an MD approach for everything, but particularly for discharges. So all of our discharges, we got the MS Teams calls together and we made MDT decisions. So we put the team around the person. There was no time for us to send individual referrals and scrutinise those to make sure all the data was correct. We just had to get around the person and talk as an MDT, and as a result, really good things happened at pace. Then we did have to start to document, because as Sarah said, we do love a process in health and social care, and for some it is an enabler for them to see it on paper. So things happened at pace. Flowcharts were worked out on bits of scrap paper and WhatsApp to each other and put into some sort of PowerPoint and shared through either emails and group sessions. But it is important for some people to see these changes written down. So at the point we could do that, we did do that. And it was really important to make sure that all the way through this, people had a forum, a safe place to come in and talk about what's working and what's not working. And it was really important, I think, for us to listen to those individuals. If you're trying to make a whole system change, then you need to make sure that everybody in that system has had an opportunity to talk about their personal issues and barriers, because if you don't unlock them, then the whole system won't move at the same time. So making sure that we were able to touch base with the teams and review how they were feeling was really important. And I'll pass you over to the newly named FlowJo.
Thanks for that, Claire.
You're
welcome. Apologies for the hiccup earlier, Callum. I had issues with my laptop, so do apologise, everybody. So yes, I didn't see FlowJo until everybody else saw FlowJo this morning, so here we are. But thank you, Claire. So if we look at system enablers, what did we use? How were we able to communicate? And as Claire says, one of the essential things, well, we embrace the use of our technology, MS Teams, Zoom, Skype. All of that was kind of not hot off the press, but to some people it was, wow, we haven't used this before, and actually kept people engaged and linked in, where some were actually feeling quite isolated, where they were either shielding at home, feeling isolated and alone. So it not only brought us together to initiate and roll out the hospital discharge guidance, but it brought everybody together that you wouldn't normally, you would normally see in an office down a corridor. So technology, definitely we have embraced that, as well as flowcharts and conversations, calls, etc. We set up an MST Teams daily call. So that was focused around Great Western, and we had all partners on that call. So from health and social care, community, acute, down to equipment, our continuing healthcare teams, our brokerage services, everybody you could possibly think of that we would require some support from to be able to expedite discharges joined that call. The sign up was absolutely incredible. So we've been having those, we were having those twice daily. We still have those calls now, but we have worked to the criteria to reside documentation, and we, instead of having them twice daily, we've stepped them down to daily. So they've been, again, really positive, well received, and it keeps everybody working to the same process. So 3 key things we did stop. So cessation of CHC and fast track assessments. Don't need those in hospital. Let's get those patients out and assess them for ongoing needs once they're out of the acute setting. Social work assessments, again, waiting for social work allocation, waiting for assessment, days delayed there. Bringing people together to have those discussions. So Claire, for Swindon and also Wiltshire, moved their social work teams outside of the acute so that they could be pulling those patients out with our therapists and nursing services to be able to do those assessments out of the acute setting. And the funding decisions also were stopped within the acute. So 3 key things that were days delayed for an acute hospital. We stepped on that straight away, and we could see a significant impact from that. Promotion of the trusted assessor. So we have 1 trusted assessor, so currently don't have a lot of resilience there. However, she came into post just about 3 weeks pre-COVID, and took to the role like a duck to water. Has been absolutely fantastic and key for those care homes, taking the patients back and also preventing them coming in. So she's been absolutely key and a good part of the system to be able to support the care homes. Quite early on, we noticed that some care homes were shutting their doors because they didn't want to bring COVID into the home, but also protecting their staff and residents. But we knew that there were a lot of beds available out there, and actually we needed their support. So what we did for Swindon was we set up a care home cell. And we met, initially we met 3 times a week so that we could talk through any issues or concerns that care homes were having. The group for the care home cell, again, was multidisciplinary. So we had representatives from Swindon Community Services, social work teams, local authority contracts teams, CCG, quality and acute. So we had set up key coordinators who took 5 key homes across Swindon, and that included learning disabilities and mental health. So all working together to talk through any issues or anxieties care homes had about taking patients back that were at the Great Western Hospital. So that again has been a success, and we've continued to keep that cell in place. And instead of having 3 times a week calls, we have weekly calls, but obviously step it up as we did a few weeks ago when we seen an increase in cases across the Swindon locality. So it stepped up and down as required, but again, been a huge success. Implementation of care homes of Restore 2. So, yep, key discussions early in COVID around Restore 2 between our quality team and AHSN. Again, some webinars and discussions, close conversations with homes on what impact and how this could improve and prevent people going to an acute hospital. The uptake has been good. That is a rolling programme now, so we've not got all care homes using Restore 2, but one of our key homes that sits under SBC has been doing some video talks, webinars, etc. to engage those care homes that haven't currently come on board yet. So we're rolling that out. Our aim is, once we've got care homes up and running, and we wanted to have it kind of before the end of this year, was then to also look at our domiciliary providers and how we can use Restore 2 to support them. One identified source of patient level information. This has been a huge move forward for us. So Nerve Centre. Nerve Centre is the patient electronic system that Great Western have on site. We all now have access, so we've gone through governance and SBC, all our partners have access to Nerve Centre. We have live lists through Nerve Centre. All the referrals are coming through there. So Claire's team from SBC, our community services, can log in, receive the referrals, and they can update their actions on there. So we've got a true reflection of what the system is looking like. We also use Nerve Centre to do our daily MS team calls, so that we can look at any issues or barriers to discharge. Next slide. So community enablers. So again, early in the response to COVID, we set up a discharge hub. So that was acute, community and voluntary sectors. So coming together to support quick, safe discharges. As we said, our priority was we've stopped all the assessments. We just want to get those patients out as long as it's safe and do all that prep work and assessment work outside of hospital. Partners, again, as we talked in the previous slide, on the daily calls, stores, mental health, community therapy, brokerage, everybody came together and are still working together to review those daily patient lists. Lead provider working differently alongside the therapist, so reduced length of stay to 3.5 weeks in pre-assessment care, and again that's guided and supported by Claire and her team, along with community services that manage the therapists in the community. We've also had the acute therapists move out of the hospital, so intensive care therapy was obviously essential to stay there. Any other therapists moved out and worked with our social workers and our community services to be able to review those patients, reducing the length of stay on those pre-assessment routes. New for us, fast track referral process for therapy in the community. Again, that absolutely sped up the review, so the assessment, the review and reducing down of packages and ongoing rehab. Podiatry was a huge success as well, so they stood down their services, but what they were able to do was to support our community services, nursing services, particularly around the increase in referrals that they were receiving because of the number of patients we were getting out of hospital. So we had podiatrists trained up to do wound care above and beyond what they're already trained to do. We had therapists looking at nursing, simple nursing tasks, and nurses looking at therapy tasks. So looking above and beyond your own profession, really. Engagement from community public health, so they were offering practical support, so for discharge, lift and a shift, shopping and prescriptions, anything again that was non-health or social care, so linking in with the Live Well hub, supporting any patients through the voluntary sector, really good uptake there. It also gave staff permission to think beyond their professional boundaries. So we talk about, you know, podiatry, doing wound care. This gave people, you know, some innovation to look at things differently and give them permission to try things. But we all came back together and reviewed it. If it worked, we kept it. If we didn't, we looked at what else we needed to do. Next slide. So the challenges, well, there were a lot of challenges, and I think, you know, across the system we're still experiencing challenges, but the pace of change, I think for teams and services, whilst they were quite excited and responded to it, it is constant, it's repetitive, and as you think you're getting somewhere, then the goalposts change. So it's forever, you know, keeping that communication link, working together, sharing the same process or the same SOP to make sure that we're all working together for the same outcome. Change fatigue, absolutely. You know, we had people working above and beyond, excess days into extra hours, and that does have an impact. You know, long term you can't sustain that, so it was around, you know, appreciative of what the staff could do, but looking for additional staff to be able to support where we could. challenge of business as usual on top of COVID. So as we've come through and started to recover from COVID, we're starting to get our business as usual back in order. However, that on top of responding to COVID and continuing to respond to COVID has been a challenge, and again it's tiring. Now we're preparing for winter, so you've got that COVID plus winter plus BAU, and it's about how we support each other, those staff members, particularly the junior staff, on how we're here to support them. Leading change and innovation remotely. Well, I've quite liked it. Although I miss being out there on the wards or, you know, in the community with the teams, working with them, it's freed up some additional time for me to be able to support further those teams. So I know that the other areas have found that a real challenge, where they're used to being in a room and seeing people face to face. However, MS Teams face to face has kind of resolved some of the issues, but yeah, it has been a challenge for some staff. Winter, so yep, here we are preparing for winter, looking at what additional capacity we need, what additional capacity we currently have. Where's the demand? Where do we need to move? You know, look at the capacity versus the demand, looking at a COVID, another wave. So again, it's increasing. The challenges are increasing. So we just need to be prepared for that and support each other. And technology, well, as you saw earlier, my mute wouldn't come off mute for me to introduce myself. So it can be a challenge. Whilst it has been absolutely brilliant and got us through the last kind of 6-7 months, it can be a challenge. So that's the end of our slides. Thank you for listening, and we'll take any questions as Callum will go on to shortly. Thanks, Callum.
Thank you very much, Joe and Claire, and for Sarah. That's fantastic, and I think it's really great to hear about how a system has kind of operationalised the guidance that came out in March, and then again the policy that was published in August. So I'm going to hand you over to my colleague Angela Bullivant in the chat room, and she will direct some questions to the speakers. So thank you for posting all of your questions. It seems as though we've got lots to go through, so we'll try and get as many of them done now in the next 20 minutes or so.
Thanks, Callum. Sarah, I'm just going to come back to you first, please. How do we manage to, with the reduced workforce due to the current pandemic and the increased workload, how have you managed that?
Sorry, who was that to?
That was to you, Sarah.
Oh, okay.
How have you managed with a reduction in workforce?
Okay, I work for the local government association, so I don't manage staff at the moment. What I do know, though, is that people have used much smaller assessment tools to enable them to make the right decisions for people in leaving hospital. And Callum, actually, you were talking about one that people have used in Brighton, and I'm sure Swindon have used them. And it's about making sure that you use the time more cleverly, I suppose, or effectively, to get absolutely using the ethical framework, the right conversations to happen, but we release staff from some of the admin and process that they used to have. Certainly when we were doing notifications in the previous guidance, that took a lot of managing and completing, and lots of unnecessary forms and process that, as Swindon have just said, they've taken away. And I think it's about trying to get the right balance between the number of staff that you need to have in the acute hospital to keep the understanding around MCA and other things happening, and that may be a leadership managerial role rather than a social work role, and then the number of staff that you actually have out in the community doing the face-to-face or the virtually face-to-face work with people to support them and assess and review accordingly. It's trying to think through the balance more than the numbers, but also the tasks that you might want to say, OK, we don't need to do that anymore. Let's do this differently.
Thank you. So with that in mind, what measures have been put in place, do you think, to protect the mental health of the workforce in the current difficulties?
Well, that's a brilliant question, and actually Swindon colleagues might want to talk about what they've done. There is a lot of work that's happened with the NHS at regional level, and certainly in the South East we've done some work, ADAS and the NHS, to look at how do we support staff who are carrying out difficult assessments, but also, you know, hearing of colleagues and friends who might have become infected, you know, and even worse, that might have lost their life in this pandemic. And it's about giving people time to talk about that. And I think the difficulty in the current pressures, and sometimes you used to have those conversations face to face when you were in some kind of team room or something like that, and it's about thinking through virtually how can you set up that opportunity for people to have those conversations, to express their fears, and to talk about things that actually are really important to them and that might be happening in their private life. I've never been a subscriber to the view that you don't bring your personal stuff to work, because actually, I don't know about you, but I don't suddenly turn off. My family probably think I forget about them the minute I start working, but that doesn't turn off in my head. And it's unrealistic for us to think, particularly at the moment, that people do that when they come to work. But we have to think about other creative ways of responding to that in the virtual world.
So do you think that some of those changes are going to be sustainable post-COVID?
I think so. I was interested in Jo's comment from Swindon about how she's quite enjoyed the virtual stuff. I mean, we've been doing virtual peer reviews in the LGA, and actually some of the conversations can be quite empowering, particularly if people want to turn their camera off and have a bit of a discussion about things that maybe they might not have done face to face in the workplace. You can have different conversations, and I would like to see us preserve some of this post-pandemic. I'd also like to see, I don't know about you, but that whole thing about, you know, getting the mix and match right between what can you do virtually and what can you do by having to go into an office with all the commuting and the other stuff and the pressure of driving or travelling that can bring, and actually preserving some time for people. I think it is really hard, but carving out just half a day in the week where you're not having sort of business contact, you're actually having some time for yourself to think about your job and how you're doing things, to manage your diary, is really, really important. But I'd really like to hear Swindon colleagues' views on that, because I think they will have some more up-to-date views probably than me.
So Claire and Jo, do you have anything further that you'd like to add to that?
Yeah, sure. I think yeah, Sarah's absolutely right. There was a huge step up. So through our public health teams, we saw far greater collaborative working between us in adult services and our public health teams, with the establishment of a community resilience hub. To not only make sure we were looking at the resilience and the well-being of people in the community, but we were looking after ourselves as well. So we nominated well-being champions and got a lot more of them than we'd had in the system previously, to make sure that they were checking in with people. Our learning and development team really stood up with lots of new learning and development about resilience and managing stress and emotional well-being and loss, because as Sarah said, you know, there was the parallel with the pandemic affecting people personally as well as professionally. But actually, I think I was just really proud of how people stood up and supported themselves. So without even instigating it, you would just find out that a team's suddenly doing a WhatsApp coffee morning, or baby showers over MST, or they're having a Skype call and a team quiz. I mean, quizzes became a thing, right? Everybody was doing a quiz, and really, you know, great things like competitions around the cutest and the ugliest pet. I mean, you know, we're the welfare services, so actually I'm really proud that as a welfare service we stood up and we took account of our own welfare and put our arms around those people next to us quite spontaneously, and I think that will always carry on. I think that's been one of the real benefits of what's happened to us all.
Absolutely, completely agree. And Claire, that's for what Claire is saying, that's Swindon as a locality, not just for social care. You know, we've really come together across health and social care as a system, supporting each other and putting arms around each other. So it's supporting each other. Going back to when I said I actually like it, the additional capacity it's given me to be able to support the system by using MS Teams and working remotely, is that I'm not travelling, you know, 2.5 hours out of my day travelling up to Great Western and back, or to Salisbury, you know, to the acute hospitals. I'm using that time to look at research, what's worked well in other areas, how can we fit that into Swindon, also across BSW. So for me, it's given me additional capacity to be able to support colleagues across the Swindon locality to improve flow for the residents of Swindon.
Thank you. So just moving on now, so probably more for Swindon colleagues, how did you manage the transition of social workers out of the acute trust with the acute team?
It was probably one of the scariest moments of my career when I realised, standing in the middle of Great Western Hospital, where we barely let these individuals out to get a grasp of daylight, and I was stood there on my own thinking, in a minute I'm going to turn around and I'm going to tell the team, you're all going to go home today, and we're going to carry on doing what we're doing at the pace we're doing it, but doing it from your own home. And I was just stood there thinking, I didn't have the words, and I just literally sat them all down and said, this is how I'm feeling, this is the challenge, this is what we're going to have to do. I need each and every one of you to give me 10 reasons why it won't work, because I've got about 12 hours to fix all of those problems so that tomorrow morning it will work. And we literally just went around the team and asked every single person to say, give me your reasons why this won't work. And I think, to be honest, people were in shock at the concept of it to begin with.
Yeah.
But again, incredibly proud. People understood, you know, there was a real clear mandate to do what we did, and that helped, no doubt. But yeah, we just got into the business of understanding each and every person's particular barrier, and that gave me a really clear action plan of things that I needed to work through. Pulled all my colleagues around me to help me do that, a lot around IT and different people needing different sorts of laptops with different bits of software on it, and then just kept talking with them every day to make sure that we had achieved the things in the right order and created the right priorities to change first. But it was a monumental moment in my career, I think.
So in relation to the discharge to assess, did you do anything around the communication for that within the acute trust to inform the patients and relatives about it?
Yes, I think we, Joe might know more than this, but I think we made use of the national templates that came out and the leaflets, so that people were aware of what we were doing and why we were doing it. So I think the communications, despite the speed of change, I think the communications that came out were really useful, and we developed our own internal comms to people that could explain what it was we were doing and set the scene and where we were doing it, and that was used also in our recordings. So all of our discharges have a kind of statement around them in our systems that explain this discharge took place during the pandemic, and that may be why, if we look back on those in the future, things would have happened differently. So yeah, we use the national tools, but we also developed our own.
Thank you. And which therapy groups have moved out of the hospital, and also how long after discharge did they follow up the patients?
We wanted quite early on, we didn't want to set ourselves a timescale on that, because for some people they might not have needed to see anybody for a number of days. For other people, they may have needed to have met a therapist there on the door. So we saw two things happen. I think we saw a change in the way we used our internal therapy resource within the acute and the jobs and things that they were doing, and that we handed over much quicker to our therapy teams in the community, and having both those teams on those daily calls enabled us to ascertain who's the best person, who's going to add the right value to this person at the moment. So sometimes community pulled out a bit earlier, and sometimes therapists held on and did what they needed to do because that was the quickest and best thing for that individual. So it was that team around the person that made those decisions every day, that are still making those decisions every day, that made the difference.
Thanks, Claire. And it was really refreshing to hear you talk about the action cards. Did you have any pushback from any of your staff around some of the changes within their roles or responsibilities that the action cards may have asked for?
No, I think they came at the perfect time, because I think we'd already started doing things differently, but we didn't really have any kind of document at that point to nail down what it was and why we were doing those things differently. So I think they landed at the right time, because people then were able to look at them from our side in the local authority and think, oh, we are doing the right things. They were used as a kind of confirmation of that, but also then they were used for us to be able to start to support and challenge people around us to do things differently. And they were real enablers. It gave people permission to do things differently and to think differently, but also to challenge their colleagues to do the same. So they were, yeah, really good.
Claire, that's quite funny to say that, because actually we had them written in April and we were waiting for months to have them published. So the fact that you think it's good timing when we were completely frustrated is quite ironic, but thanks.
Sorry, Callum, you've thrown me now. Did your community therapists as well, did they conduct any moving and handling assessments and provide any handling plans for community care?
I wouldn't know the exact detail of that, but they must have done to do the things that have happened. They were absolutely involved wherever they needed to be, and all the usual kind of referral processes were stood down. We just had a conversation around the call about what was needed, and the person was taken out. So I know there were lots of care packages where we were unsure whether we were going to need a big package or a small package, and those could be reviewed, that afternoon, and those decisions made really quickly.
Were there any parts of the policy that you weren't able to implement, or as a whole were you able to implement it in full?
I think we have still got a way to go around understanding the opportunity of the trusted assessor. And I think if we're really honest, as a system, what we did was we got into the business of accelerated discharges rather than true discharge to assess. So I think we did things really quickly as a whole system. But we were still making a certain level of decisions within the acute, which now in a more planned way we're not doing, and we're moving toward proper discharge to assess and just having a basic level of information on that individual and asking the wider questions from both therapy and social care when that person gets home. So I think we're on our way now, but I think early days we were probably not achieving the full D2A. It was more the accelerated discharge model. So that is now rolling out across the whole hospital, the true D2A, and I think the trusted assessor is a role that we can absolutely make much better use of. And I think understanding your pathways, so the work that Joe did around the system, which is reflecting to the whole system, not just the whole green to go number, but what that means for individuals on individual pathways, that was really powerful. Were able to get the right people around the call so they could almost take responsibility for their pathway to make sure that they had either the reablement support or the bed base, or they were going home independently, so the wards were. So I think using that we didn't do that early on, but we're doing that now, and that's really helped us.
And then could I just ask you just to clarify something for me, and it's probably my fault for answering the question in a convoluted way, but with regards to the therapists, is it right in thinking that the staff were located in the acute trust but were discharging the patients quicker? I think Lynn was just concerned that there might be a bit of a mixed message, and I say that's probably my fault for the way I've asked the questions previously.
And I'm definitely not a therapist, so this is not my area of expertise, but there were therapists owned by the trust, so the therapists that belong to Great Western Hospital team, and there are therapists that belong to Swindon Community Health Services. So I think all of our therapy teams are doing things differently, but our therapists within the acute didn't need to come out to the community because we already have therapy in the community. But I would imagine if my therapy colleague, and he was a big part of our success,